Today I will discuss short-term regulation of blood pressure, and it is exactly the right question for anesthesia. We are not talking about abstract cardiovascular physiology here. We are talking about what happens in real time when the blood pressure on the monitor suddenly falls after induction, drops after a spinal, or swings during hemorrhage, ventilation changes, or positioning. The central question for this lecture is simple. When blood pressure changes suddenly, how does the body detect it? And what does it try to do before we intervene? We will walk through the baroreceptor reflex, chemoreceptors, the CNS ischemic response, and atrial stretch receptors, and we will keep coming back to the same practical framework: trigger, sensor, central response, effector response, and clinical consequence. So as we start, keep the mental picture in the OR. A patient is stable. Then something changes. Maybe the propofol goes in. Maybe the surgeon lifts the legs. Maybe the blood loss starts. The number on the monitor moves first. Then the body reacts. Your job is to recognize which reflex is trying to help and whether it is enough. That is why this topic matters clinically. In anesthesia, we often create abrupt hemodynamic changes, and the patient's short-term reflexes are the first line of defense. If you understand those reflexes, you can predict the direction of compensation instead of just reacting to the number. So think of this lecture as bedside physiology: what the body sees, what the brain does, and what the heart, vessels, and circulating volume do next. Our learning objectives are straightforward. First, identify the major factors that regulate arterial blood pressure and explain how each one changes the number you see on the monitor. Second, understand why short-term regulation matters so much in the operating room. Third, learn the main rapid reflexes that respond within seconds to minutes. And as we go, I want you to keep one equation in mind: arterial pressure equals cardiac output times total peripheral resistance. If the pressure changes, something has happened to the pump, the vessels, or the circulating volume feeding the pump. That simple framework will make the reflexes much easier to interpret when we get to induction, hypotension, spinal anesthesia, hemorrhage, positive pressure ventilation, and changes in position. At a high level, regulation of blood pressure is about keeping perfusion adequate for the brain, heart, and kidneys. While the body is constantly being stressed by posture, volume shifts, breathing, pain, anesthetic drugs, and bleeding. The body is always sensing, it is always comparing, and it is always trying to correct. The important thing for residents is to separate the timescale. In the first seconds and minutes, neural reflexes dominate. Later, volume and renal mechanisms take over. So when we see a sudden drop in blood pressure, we should ask, is this a fast reflex issue, a pump problem, a vessel problem, or a true volume problem? That question guides what the patient is doing on their own and what we need to do for them. Here's the core relationship. Arterial pressure equals cardiac output times total peripheral resistance. That is the whole game. You can raise arterial pressure by increasing resistance, by increasing venous return and cardiac output, or by directly increasing heart rate and contractility. In anesthesia terms, if propofol reduces sympathetic tone, you lose vascular tone and sometimes preload. If a spinal blocks the sympathetic chain, you lose arteriolar and venous tone. If hemorrhage reduces circulating volume, you lose preload first, then cardiac output falls. So when blood pressure drops, do not just ask what is the pressure. Ask, is the pump weak? Are the vessels dilated? Or is there not enough volume getting back to the heart? That is the practical bedside lens. The autonomic nervous system is the control system underneath all of this. The sympathetic nervous system is the major regulator of circulation. It affects arterioles, veins, and the heart. The parasympathetic nervous system, in contrast, is mainly about heart function, especially heart rate through the vagus nerve. So if you want to think clinically, sympathetic tone is the main lever for vascular resistance and venous capacitance, while parasympathetic tone is mainly a brake on the heart. That matters when a patient becomes hypotensive under anesthesia. Sometimes the issue is loss of sympathetic tone. Sometimes it is a reflex increase in parasympathetic activity slowing the heart. And sometimes both are happening together. This slide is a reminder that sympathetic fibers reach almost all vessels, with important exceptions like capillaries and precapillary sphincters. That widespread innervation is why the sympathetic system can rapidly redistribute blood flow. Small arteries and arterioles matter because they set vascular resistance. Large veins matter because they hold volume and influence venous return. The heart is also sympathetically innervated, so the same reflex can increase rate and contractility. On the parasympathetic side, the key clinical point is simpler. Vagal tone mainly slows the heart. So when you see a pressure change, ask which part of the circulation is being targeted. Is it the arterioles, the veins, or the heart? That distinction helps you understand what the body is trying to fix. This is the organizing concept. Mean arterial pressure is influenced by heart rate, stroke volume, vascular resistance, and venous return. Sympathetic activation generally pushes all of those in the direction of higher pressure, faster heart rate, stronger contraction, more venous constriction, and more arteriolar constriction. Parasympathetic activity mainly works on the heart, especially lowering heart rate. So if you want the shortest possible bedside summary, it is this. Sympathetic activity supports pressure through both pump and vessels, while parasympathetic activity mainly reduces the pump. That is why a vagal episode after laryngoscopy, traction, or neuraxial anesthesia can produce sudden bradycardia and hypotension. You can already see the logic before we even get to the specific reflexes. Now we move from the broad framework into the rapid regulatory mechanisms. This is where the anesthesia resident should really pay attention, because these are the systems that respond while you're still looking at the waveform, still deciding what drug to give, and still asking whether the patient needs fluid, vasopressor, or both. The body does not wait around. It senses the change and responds immediately. Some of those responses are fast and elegant. Some are powerful but reserved for severe stress. The key is to know which one is likely active in the first few seconds, and which one becomes more important if the problem continues. The short-term regulators are the baroreceptor reflex, chemoreceptors, the CNS ischemic response, and atrial stretch receptors. These are the systems that act within seconds to minutes. For practical anesthesia, the baroreceptor reflex is the one you will think about most often. It is the classic buffer against sudden changes in pressure. Chemoreceptors become more relevant when perfusion is falling and oxygen delivery is threatened. The CNS ischemic response is a last-ditch, high-gain emergency mechanism, and atrial stretch receptors help the body respond to changes in volume. So the framework is simple: detect the disturbance, signal the medulla, and adjust heart rate, contractility, vascular tone, and volume handling to restore pressure. Baroreceptors are pressure receptors in the carotid sinus and the aortic arch. Their job is to sense stretch. More pressure means more stretch, less pressure means less stretch. Those signals go to the cardiovascular centers in the medulla oblongata, which then adjust sympathetic and parasympathetic outflow. Clinically, this is the fastest and most familiar reflex for moment-to-moment blood pressure control. If a patient stands up, if they are induced, if the spinal level rises, or if venous return falls, these receptors are among the first sensors to notice. So again, the flow is trigger, sensor, central response, effector response, and then the blood pressure you actually see. When you look at the baroreceptor curve in physiology texts, what matters is not the figure itself, but the idea behind it. Baroreceptors are sensitive to changes around the normal operating range, and they translate pressure changes into changes in firing rate. That means they are excellent at buffering short-term fluctuations. They are not trying to provide perfect long-term control. They are trying to keep the patient from swinging dramatically every time posture, anesthesia depth, or ventilation changes. In the OR, that is exactly what we need to understand. We do not need a memorized graph as much as we need the practical idea that these receptors are always watching stretch and adjusting autonomic output accordingly. The important conceptual point here is that the body is always comparing the current pressure with what it expects as normal. That comparison happens continuously, not just during emergencies. So when a patient becomes hypotensive after induction, the baroreceptors are not passive. They immediately reduce their firing. The medulla reads that as a drop in pressure, and the body responds by increasing sympathetic tone and withdrawing vagal tone. That is the reflex we are about to build on in the next slides. Keep that in mind, because the same basic pattern shows up repeatedly. A drop in stretch leads to a rise in sympathetic drive, and the effect is to support heart rate, contractility, resistance, and venous return. The baroreceptor reflex is why blood pressure stays relatively constant when we change posture. Think about a patient going from supine to standing. Blood pools in the lower body, central blood volume falls, cardiac output falls, and arterial pressure begins to drop. The baroreceptors sense that fall and signal the vasomotor center to increase sympathetic activity. The result is vasoconstriction, increased venous return, and supportive pressure. So the reflex is acting before the patient fully faints. In anesthesia, you can think of the same thing after a head-up position change or after the drapes are adjusted. The principle is the same. The body is trying to preserve blood flow to the brain by tightening the vessels and supporting the pump. The baroreceptors oppose both rises and falls in arterial pressure, which reduces the day-to-day variation in blood pressure. But they are not a long-term control system because they adapt. If pressure stays high or low for a while, the the receptors reset and the reflex loses some of its effect. That is clinically important. It means the baroreceptor reflex is great for rapid buffering, but not for chronic blood pressure management. In the OR, though, rapid buffering is exactly what we care about. We are often creating abrupt changes with drugs, ventilation, or surgical manipulation, and the baroreflex is the body's first attempt to smooth that out. So think of it as a short-term stabilizer, not a long-term solution. If you want a clean mental model, imagine the baroreceptors as an automatic pressure buffer. They are not deciding whether blood pressure is ideal in some abstract sense. They are simply reacting to stretch and trying to prevent sudden swings. That is why a patient can look fine at baseline and then become hypotensive as soon as the physiology changes. The reflex begins immediately, but it may not be enough if the insult is large. In that case, the body's attempt to compensate tells you a lot about what kind of problem you're dealing with. Fast drop, think reflex and preload. Slow persistent fall, think volume, vasodilation, myocardial depression, or all three. At normal arterial pressure, baroreceptors are firing all the time. Increased pressure increases their activity. Decreased pressure decreases their firing. That tonic activity is important because it gives the medulla a baseline signal to work with. When pressure falls, the loss of firing itself becomes the message. The body then responds by increasing sympathetic output and supporting the circulation. This is especially useful during rapid changes, like standing after lying down. That is why they are called pressure buffers. In the OR, the same principle applies during induction or after a blood loss event. The question is not simply, is the pressure low? It is, how rapidly did it change and what reflex response is already underway? So let's make the baroreceptor reflex concrete. The trigger is a change in arterial pressure. The sensor is the carotid sinus and aortic arch. The central response occurs in the medulla, and the effectors are the heart and vessels. If pressure falls, firing falls. If pressure rises, firing rises. That sounds simple, but it explains a lot of bedside behavior. A patient with spinal anesthesia loses sympathetic tone, pressure falls, and the baroreflex tries to compensate with tachycardia and vasoconstriction. A patient with deep induction may have blunted reflexes, so the body tries to respond but cannot keep up. That mismatch is when you need to step in. When MAP goes up, baroreceptor firing goes up. The medulla responds by increasing parasympathetic or vagal activity and decreasing sympathetic activity. Then heart rate falls, stroke volume may fall, and total peripheral resistance falls. The net effect is to bring pressure back down. This is a negative feedback loop. In practical terms, if a patient becomes hypertensive during light anesthesia or laryngoscopy, part of what you're seeing is the body's own reflex attempting to resist the rise in pressure. The body senses the stretch and immediately leans towards slowing the heart and relaxing the circulation. So the leverage points are the pump and the vessels, and the direction is down. When MAP goes down, the opposite happens. Baroreceptor firing decreases. Parasympathetic activity falls and sympathetic activity rises. Then heart rate increases, stroke volume is supported by stronger contraction and better venous return, and total peripheral resistance rises through vasoconstriction. That is the body trying to rescue pressure. In a patient after induction, this is what is happening in the first moments. The baroreflex is calling for more sympathetic tone. But if the anesthetic has blocked sympathetic output or the patient is volume depleted, the compensation may be incomplete. So if you see hypotension, ask whether the baroreflex is intact, whether it is being overridden, and whether the problem is really a pump, vessel, or volume issue. This is the practical takeaway. Baroreceptors are the first rapid defense against pressure swings, and they mainly protect the brain during sudden postural or anesthetic changes. They do not correct every problem completely. They buy time. That is the point. If the blood pressure change is mild and transient, the reflex may be enough. If the change is larger or the patient is unable to compensate because of anesthesia, age, autonomic dysfunction, or severe hemorrhage, then the reflex tells you what the body is trying to do, but you still have to intervene. So when you see the monitor move, ask yourself, what is the reflex trying to preserve right now, and what has it failed to preserve? Posture change is one of the clearest demonstrations of baroreceptor function. When a patient goes from supine to erect, blood pools below the diaphragm, central blood volume falls, and MAP in the head and upper body drops. Baroreceptors sense that change and activate a strong sympathetic response. The result is vasoconstriction, which minimizes the fall in MAP. That same story matters in the OR when we change head position, tilt the table, or sit a patient up. The physiology is not mysterious. The body is defending perfusion to the brain by tightening vessels and supporting venous return. If that response is blocked or overwhelmed, the pressure falls further, and the patient may become symptomatic or lose consciousness. Hemorrhage is another classic example. The trigger is loss of circulating volume. That reduces venous return, then stroke volume, then arterial pressure. Baroreceptors detect the fall and stretch and trigger sympathetic activation. The immediate response is vasoconstriction, tachycardia, and support of the heart and vessels. That does not replace the lost blood, but it helps preserve perfusion to the brain and heart for a while. This is why a patient can look relatively compensated early in bleeding, even though the volume problem is getting worse. The reflex is trying to maintain pressure despite less preload. Clinically, that means you should not be reassured by a temporarily normal heart rate or blood pressure if the bleeding is ongoing. This is a negative feedback loop. The change in pressure is sensed, the reflex acts, and the action pushes pressure back toward baseline. If pressure falls, sympathetic output rises and pressure is restored upward. If pressure rises, sympathetic output falls and pressure is brought down. That is why this system is so useful in the short term. It is self-correcting. But it also has limits. It cannot fully overcome severe vasodilation, profound blood loss, or deep anesthetic suppression. So in the OR, you use the reflex as a clue. If the patient is tachycardic and vasoconstricted, the body may be trying to compensate for low preload or low resistance. If the patient is bradycardic and vasodilated, the reflex may be impaired or overridden. Now let's move to chemoreceptors. These receptors are interested in oxygen, carbon dioxide, and hydrogen ion levels. They have a very high blood flow, so they are well positioned to detect changes quickly. The important clinical point is that they become relevant when perfusion is falling enough to threaten tissue oxygenation. Reduced blood flow can stimulate them through low oxygen, higher carbon dioxide, or increased hydrogen ions. When MAP falls below a critical range, this reflex becomes more important. Unlike some reflexes that slow things down, this one is excitatory. It mainly activates the sympathetic nervous system. The body is essentially saying, perfusion is getting bad, so tighten up and protect the vital organs. The carotid and aortic bodies are the main peripheral chemoreceptors. They sense oxygen lack, carbon dioxide excess, and hydrogen ion excess. When they are activated, they excite the vasomotor center and increase sympathetic activity. The net effect is redistribution of blood flow away from less essential areas and toward the brain and heart. One way to remember them is this: they care about the chemistry of perfusion, not just the pressure number itself. In severe hypotension, especially when pressure falls low enough that tissues are underperfused, these receptors help drive the body toward vasoconstriction and support of circulation. So if baroreceptors are the first buffer, chemoreceptors are the alarm that says the situation is becoming metabolically dangerous. In the operating room, this is where the story gets more urgent. If the pressure is low enough for long enough, the issue is no longer just hemodynamics. It is oxygen delivery. That is why chemoreceptor activation matters. The body is not only detecting pressure, it is detecting the consequences of low flow. And that helps explain why a patient who is hypotensive and hypoventilating, or hypotensive with poor perfusion, may begin to mount a stronger sympathetic response. The chemistry of the blood and the pressure on the monitor are linked. When both are moving the wrong way, the reflexes are trying harder, and that is a sign you need to treat the cause quickly. The CNS ischemic response is the emergency reflex. It operates rapidly to prevent further decline in MAP when blood flow to the brain itself becomes critically low. If MAP falls very low, the vasomotor center becomes ischemic, carbon dioxide and lactic acid accumulate, and the sympathetic vasoconstrictor system is powerfully activated. This is one of the strongest vasoconstrictor responses in the body. Clinically, it is a last-ditch effort. It is not the reflex you rely on for routine compensation. It is the reflex you think about when the pressure is so low that cerebral perfusion is at risk. The body is essentially throwing everything it has at the problem to preserve flow to vital organs. Atrial stretch receptors respond to blood volume. They are located in large veins near the heart and in the atrial walls. When blood volume increases, the atria stretch, afferent signals go to the medulla, and the cardiovascular center is inhibited. The result is a set of responses that reduce volume back toward normal. Less sympathetic drive to the kidney, less renin, less RAAs activation, less aldosterone, less ADH, and more atrial natriuretic peptide. So this is the volume sensing side of short-term regulation. In the OR, think about fluid loading, transfusion, or sudden changes in venous return. The body is constantly asking whether the central circulation is too full or too empty, and these receptors help answer that question. Once we move beyond the first seconds and minutes, the body starts using intermediate-term mechanisms. These include the renin-angiotensin system, capillary shift, and stretch relaxation of vessels. The time frame is from about 30 minutes to several hours. That matters because the patient who is still hypotensive after the initial reflex compensation is no longer just dealing with a fast autonomic issue. The circulation is beginning to move fluid, alter vascular tone, and adjust blood volume distribution. So clinically, if the early reflexes are not enough, you're moving into the territory where fluid balance and endocrine responses start to matter more. The body is still compensating, but it is doing so on a slower timescale. Long-term regulation is mainly renal. The body controls blood pressure over days to months by controlling body fluid volume. Aldosterone and renal body fluid mechanisms become the major players. In other words, long-term pressure control is really long-term volume control. That is important. But in the OR, it is usually not what explains the immediate blood pressure change on the screen. If pressure dropped in the last minute, think reflexes. If pressure has been abnormal for a longer period, then renal and hormonal regulation matter more. So keep the timescale straight. The body is always regulating, but different systems dominate at different times. So let's pause and outline the short-term regulators of blood pressure. First, baroreceptors respond to stretch in the carotid sinus and aortic arch and buffer sudden pressure changes. Second, chemoreceptors respond to low oxygen, high carbon dioxide, and increased hydrogen ion and drive sympathetic activity when perfusion is threatened. Third, the CNS ischemic response is a powerful emergency reflex when cerebral blood flow is critically low. Fourth, atrial stretch receptors sense volume and help the body adjust renal and hormonal responses. If you can keep those four mechanisms separated, you will be much better at understanding why the pressure changed and what the body is trying to do before you treat it. Let's come back to the equation one more time. Arterial pressure equals cardiac output times total peripheral resistance. That is the reason all of these reflexes matter. Pressure can be increased by constricting arterioles, which raises total peripheral resistance. It can also be increased by constricting large veins, which improves venous return and cardiac output. And it can be increased directly by raising heart rate and contractility. In practical anesthesia language, that is the pump versus vessels versus volume framework. If you know which lever is being pulled, you know what the body is attempting and what intervention makes sense. That is the bedside value of physiology. The sympathetic nervous system is the main circulation controller. The parasympathetic system is mainly about heart function, so when a patient becomes hypotensive, sympathetic tone is usually the system trying to save them. It constricts vessels, supports venous return, and can raise heart rate and contractility. When anesthesia blunts that system, the patient loses one of the main defenses against hypotension. That is why induction and neuraxial anesthesia so often cause a fall in pressure. We are removing sympathetic support faster than the patient can restore it. So when you interpret the monitor, ask yourself whether the sympathetic system is being overridden, blocked, or insufficient for the current stress. Sympathetic fibers innervate essentially all vessels except capillaries and precapillary sphincters, and they also innervate the heart and large veins. That distribution explains why sympathetic activation can affect both resistance and capacitance. Small arteries and arterioles determine vascular resistance. Large veins determine how much blood returns to the heart. The heart determines how much blood it can eject. Parasympathetic influence, through the vagus nerve, is mainly on heart rate. So if the blood pressure changes abruptly, you can usually think about a sympathetic deficit, a vagal surge, or both. The question is not just what is low, the question is which component of the circulation has been altered. So here's the final practical take-home. High-pressure baroreceptors in the carotid and aortic regions are the most important short-term sensors for sudden blood pressure changes. They are the sensors that tell the body in real time that pressure has fallen or risen. They do not fix the problem by themselves, but they initiate the reflex response that buys time. In the OR, that means the baroreceptor reflex is often already active by the time you notice the blood pressure change. Your job is to recognize what it is telling you. Is this a loss of preload, a loss of vascular tone, a bradycardic reflex, or a combination? Once you answer that, you're treating physiology, not just a number. If you leave with one mental model, make it this one. When blood pressure changes suddenly, the body first asks, what changed about stretch, chemistry, or brain perfusion? Then it tries to respond through the heart, the vessels, and the circulating volume. In the first seconds, baroreceptors dominate. If perfusion worsens, chemoreceptors and then the CNS ischemic response become more important. Atrial stretch receptors help the body think about volume. So when you're in the OR, do not just see hypotension. Read the pattern. Ask what sensor fired, what the medulla did, and which lever the body pulled. That is how physiology becomes clinical judgment.